Thank you guys for coming. I wanted to talk to you guys today about shock, because I think shock is a very important concept when we're talking about coronavirus. There's a couple of reasons for that. One is that we know that these patients are developing septic shock, but then down the road, we also know that they're later developing cardiogenic shock. So I want you guys to leave with the concept of, just because I found one kind of shock doesn't mean I stop there and stop looking for others, okay? So from your perspective, what do you think of when you think about a definition of what shock is?
Inability to support your blood pressure, multi-organ system failure.
Okay, so I sort of take it one step back from that even, and I just think of it as an inability to perfuse some organ of your body, and generally most organs of your body, okay? And most often that presents with low blood pressure is what we think of. So that's really what we're gonna be talking about as far as this goes today, okay? So shock it is. All right, so when we think about shock, we think of it as 4 brands of shock. What are our 4 brands of shock that we think of? Awesome. Hypovolemic. What else?
Cardiogenic.
Distributive. One more?
Obstructive.
Obstructive. Awesome. Okay, so what I want to talk about now is the different categories that fall under each of those categories and what we do about them, okay? So let's start with hypovolemic shock. I think that's sort of the most easiest one to process what's going on with it. So I think of 2 categories. I think of that as either hemorrhagic or non-hemorrhagic. When I think of non-hemorrhagic causes of hypovolemic shock, I think about things like dehydration, and whether that's due to diabetes insipidus, whether that's due to lack of intake, whatever the cause may be, but some reason you don't have enough fluid, okay? Or hemorrhagic, just meaning you're bleeding. So the things I want you to think about here are, what do we do about that? And so the answer to both really is fluids. In general, you want to replace what you lost. So here we're thinking about blood products initially, and then some sort of crystalloid, and here we're really just considering some form of crystalloid, okay? For hemorrhagic shock, don't only think about trauma sorts of situations. I saw a patient bleed out and almost die, actually from having a central line removed from their groin, and no one was checking the site, and so they had a massive bleed from that. So always look at your whole patient when you're thinking about these things, okay? So fluid, fluid, fluid. We want to try to avoid using vasopressors in this situation. Yeah?
Since I haven't done this in a while, is there a max amount of like crystalloid that you want to give, since it's potentially not staying in the periphery and is third spacing?
Yeah, that's a great question. So we want to use all of our other indicators that we can come up with to determine how much fluid our body needs. So we want to look at our urine output. We want to look at our ultrasound studies. We want to look at every piece of information we can put together. We'll get into a little bit more detail of that in a later talk, but that's a great question, and it's a really important one. So we don't want to over-resuscitate people either. Yeah?
When I'm giving blood, when do I need to start thinking about platelets or other products?
Yeah, great question. So in general, anytime we're talking about a massive transfusion, so anytime we might be giving more than 4 units of blood, we always want to think about adding on platelets and FFP, fresh frozen plasma, on top of that. We generally think of doing that in a 1-to-1-to-1 ratio is what the studies have shown. Often we don't have enough product to actually be able to do that. So we try to then do the 1-to-1 ratio of red blood cells and fresh frozen plasma with only a platelet when needed. Usually ends up being about 4-to-1 with platelets based on availability. Okay? All right, so those are our 2 there. For cardiogenic shock, I usually think of 3 types of cardiogenic shock. One is structural, one is arrhythmogenic, and then one is myopathic. Okay, so structural, this means valve disease, this means a ruptured wall, this means some reason that the actual structure of your heart is problematic. This needs surgery. This means that you're in AFib with RVR, or you're in VTAC, or you're in some rhythm that's not letting your body perfuse, in which case we have to fix the underlying rhythm, often with electricity, or potentially some medication might help. Okay. But then myopathic, this is where I'm talking about congestive heart failure, or if you've had an acute myocardial infarction and your heart muscle stops working, that's what we're talking about here. So both scenarios. What I really want you to keep in mind is this is what we're seeing in coronavirus after patients get over all their respiratory failure and it looks like they're turning the corner. They're then developing some cardiogenic shock. Okay? So for these people, that balance of having just the right amount of fluid in their body is even more important. And then we can think about adding like dobutamine or some other medication to keep their heart beating as strong as it can to get them through that insult. Okay, does that all make sense? Okay, so don't forget about cardiogenic shock in these folks. All right, what are our causes of obstructive shock?
Pneumothorax.
Perfect, pneumothorax, what else? Tamponade. One more, give me.
PE.
PE, perfect. So the other thing that I think of going here is sometimes if you have really massive pleural effusions, that can do it too, okay? So the treatment for all of these, they're all gonna be preload dependent states, they're all gonna need fluid up front, but the bottom line is you gotta fix the problem, right? These people need a needle decompression, and then they need a chest tube. These people need some of that fluid removed. These people need a drain to their heart, and these people need something that's gonna break up that clot somehow, okay? So those fluid up front, and then really try to solve the problem, okay? All right, and then to this sort of bigger category of shocks, what are some of our causes of distributive shock?
Sepsis.
Perfect.
Spinal cord injury.
Neurogenic. Two more. Do you know?
Anaphylaxis.
Yeah, perfect. Anaphylactic. One more everyone always forgets about. Adrenal insufficiency. Okay, what I want you to take from this is your patients are gonna get septic shock and coronavirus if they're very sick. We're gonna see that, okay? So fluids and then vasopressors are gonna be the answer to there. We'll do a later talk on specific what vasopressors to use and how to approach that situation, okay? But fluids, vasopressors are gonna be your answer here, okay? And then neurogenic shock, like you said, we think of that with spinal cord injuries. In those scenarios, we think of those people also needing vasopressors, a little less fluid than you would need with a septic shock. Anaphylactic shock, how do we treat that?
Epinephrine.
Epinephrine. These people also have massive amounts of fluid shifts. So think about giving them a lot of fluid as well. But this is the one shock where epinephrine is first line, for sure, okay? And then adrenal insufficiency, how do we treat that?
Steroids.
Steroids, perfect, perfect. So the key things I want you guys to take from this is really all of these. So for all of these, fluids is gonna be the right answer, right? For all of these, fluids up front is gonna be the answer, right? And then really the only one here is gonna be cardiogenic, where we have to be a little bit more careful about deciding how much fluid our body needs and what to do with it, okay?
Mm-hmm.
So again, we'll discuss our pressors a little bit later, but always think about all of these kinds of shock. They like to be friends. They like to go out together and hang out. They usually start isolated, but know that as the disease progresses, more shocks can come along. So never stop looking for all of these whenever you have a hypotensive patient that's not doing well, okay? Any questions I can answer for you guys?
How much fluid should I give to start with?
Yeah, that's a great question. So in general, we think of 30 milliliters per kilogram as being the right amount of fluid for that first initial bolus if we're using crystalloid fluids. That's a great question. And that usually ends up being about 2 liters. So if you give 2-liter bolused fluids, that's gonna be a great starting point.
How can I tell the difference between septic shock and the cardiogenic shock, or if there are two going on at the same time?
Yeah, that's a great question also. So we generally, if we know the patient is infected, we know they have low blood pressure with a high heart rate, this is what we think of. We look for those SIRS criteria we talk about. We look for the elevated white blood cell count, although keep in mind, with coronavirus, your white blood cell count is actually going to go down. Okay, so that's key to understand with this disease process. So look for your white blood cell count, look for your heart rate, look for your blood pressure, look for mental status changes, look, all those things are going to help you identify septic shock. The thing that's really going to help you identify cardiogenic shock is going to be looking for elevations in troponin and really looking at an ultrasound, looking at an echo of their heart and seeing if you see some abnormalities there. Even for folks who are not cardiologists, a lot of intensivists are trained to do bedside ultrasound where they can just look specifically for cardiac output and get an idea if that's changing for their patient or it looks like they're not pumping well.
Are machines like the Vigilale or other intensive purposes helpful at identifying that?
Yeah, so those can be helpful. I don't want to get into them too much in that talk. I think that's a little bit beyond what we want to cover today. That's going to be key though once the patients get up to the ICU. We can talk about more invasive types of monitoring for vital signs and other markers of shock. Anything else? Oh yeah, so let's talk about one more thing that we didn't talk about with septic shock. Okay, so I said the fluids and the pressors are what we're really going to use as far as the underlying shock goes to overcome that physiology. But if this is a bacterial process, we have to make sure that we get antibiotics on board. And for antivirals now, for coronavirus, we do have a compassionate use antiviral available. So that will be an option as well. Remdesivir is going to be the one to look for there. You do need the compassionate use exception to get that for your patient. But absolutely think about antibiotics or antivirals up front in septic shock. Great point.
So all patients potentially coming in until they have a positive test should probably be started on broad spectrum antibiotics to cover for any type of bacterial process?
Correct. We'll be able to get biofires back pretty quickly. You'll still be able to do the tests we would normally do, right? So think about all of that stuff up front and first. But yeah, we're gonna start patients on broad spectrum antibiotics if we think they have a bacterial source. Procalcitonin being low and your white blood cell count being low are really going to point us towards that coronavirus though, as opposed to a bacterial cause. Okay, thank you guys so much. Please help us out there. We really appreciate everything you do. Have a great day.